Thank you very much for this very kind introduction. So I'm really happy to be with you, and I will share my screen now. It should open. So you see my screen now? Everything's fine?
Yes, we do.
Yes. So let me start. So this is about biology of Rasopathies, and I would like to add also phenotypic variability, because this is something I will have to talk about. And you see, I have included a little bit of Greek, and this is all you can expect from me. So what I'm going to talk about is actually quite known diseases like colon cancer, congenital melanocytic nevi, Noonan syndrome, neurofibromatosis, and also a little bit about hydrops fetalis. And you may ask, so what do these disorders have in common? So it is pretty well known since the 80s that RAS is an oncogenic driver for many tumors like colon cancer, pancreatic cancer, and so on and so on. But when the first gene for Noonan syndrome was discovered in 2001 by Marco Tartaglia and Bruce Gelb and their group, it was not pretty known that there's any connection between RAS and PDP11, the first Noonan gene. But it was known that Noonan syndrome is sometimes associated with a specific type of leukemia that you know much better than I do, JMML. And it was also known that somatic mutations in RAS are also can cause this type of leukemia, and also NF1 patients, neurofibromatosis patients, can have this type of tumor. And then Marco and Charlotte Niemeyer were the first to discover somatic mutations in PDP11 in sporadic cases of JMML. And Christian Kratz actually, in a collaboration, very nice collaboration with me, discovered, based on one patient with leukemia and a germline RAS mutation, that KRAS is the second Noonan syndrome gene. And then the field opened up, and everyone saw that this is Noonan syndrome is actually a disorder of the RAS pathway. And now, today, we know that not only Noonan syndrome, but all the other syndromes of this large group of what we call now Rasopathies can be plotted onto the components of this signaling pathway, which is an ubiquitous pathway present in every cell, a module of signaling that has so many modes of action and functions that are cell and tissue specific. And what we also learned, that not only the oncogenic mutations, but also the germline mutations in Rasopathies are either activating mutations by gain of function in the agonists of the pathway, or by loss of function in the antagonists. So the common readout of the pathway is overactivation, dysregulation of this pathway. And under this umbrella of this wide variable syndromes and disorders of Rasopathies, we now have a number of categories. So one is Noonan syndrome and the related disorders, neurofibromatosis. I will talk a little bit about Rasopathies that do not have the Noonan-like phenotype, mosaic Rasopathies, and if we want, we can also count under this umbrella the RAS-dependent tumors or single tumor-like lesions that have RAS mutation or RAS pathway mutations. And the first three of the category are caused by constitutional mutations, and the other one by somatic events. So first, Noonan syndrome and related disorders. They comprise Noonan syndrome as the most common condition, and then Noonan syndrome with multiple antigenes, which is now called Noonan syndrome with which was formerly called Leopard syndrome, and other subtypes, and then Costello and CFC syndromes. And you see examples of patients with these conditions. And they all share this Noonan-like phenotype, which is characterized mainly with characteristic facial anomalies, cardiac anomalies, mainly pulmonary stenosis, hypertrophic cardiomyopathy, septal defects, growth delay, sorry for the typo, growth delay and short stature, and a number of other abnormalities in multiple organ systems including also skeletal lymphatic abnormalities, bleeding, also tumor predisposition, and neurodevelopmental defects. And this Noonan-like phenotype can be now considered the phenotypic signature of a systemic RAS pathway dysregulation. So everything that leads to RAS pathway dysregulation in every cell of the body from the early development on will result in something that we can recognize as Noonan syndrome-like. And we also recognized more recently an antenatal phenotype of Rasopathies, which includes the nuchal edema and a prenatal lymphatic effusion sequence that can even present as hydrops fetalis, and some, and of course, this nuchal, this white neck of Noonan syndrome or Rasopathy patients is a residuum of this nuchal hygroma, and in some cases, even we don't see them, the live-born children, and the hydrops and the sequence leads to death. So I mentioned already these other conditions that overlap with Noonan syndrome, but have distinct signs and features, like the multiple lentiginous in Leopard syndrome, together with hypertrophic cardiomyopathy, which is quite frequent in this condition, and deafness. The Noonan syndrome with loose anagen hair has a very characteristic hair phenotype and often growth hormone deficiency. Intellectual disability and ectodermal anomalies are the hallmarks of CFC, and also Costello patients have more intellectual impairment than Noonan, and they have, in particular, a relatively high tumor risk of childhood tumors of 15 to 20%. The second category is neurofibromatosis type 1 and related disorders, which include Lesions syndrome or schwannomatosis. And on the first glance, neurofibromatosis doesn't seem to have much in common with Noonan syndrome, because you know that this condition is mainly dominated by the neurofibromas, caveolé spots, and the neurogenic tumors that occur. But if we have a closer look, we recognize that many neurofibromatosis patients have some mostly subtle features that resemble Noonan syndrome, like facial anomalies. They have learning disabilities. They have the same type of tumor predisposition with JMML, or these giant cell lesions of jaws. They may have skeletal abnormalities, and also neurofibromatosis patients are a little bit shorter than expected from the family background. And some of these patients actually have a combined phenotype, which is called NF1 Noonan syndrome, but which is nothing else than a more severe expression of this Noonan part of the disorder, in addition to what neurofibromatosis is typical for. The third category I will briefly mention is Rasopathy without Noonan signs, which includes a capillary malformation, arteriovenous malformation, syndrome or Parkes-Weber syndrome caused by RAS-1 mutation, and a specific type of autosomal dominant mental retardation. These more restricted, non-systemic, but Rasopathies, but caused by germline mutations, are probably explained by the tissue-specific action of these genes, which are also, like NF1, inhibitors of RAS. And loss of function causes these symptoms. And this shows us that if endothelial cells are affected by RAS pathway dysregulation, these arteriovenous malformations or vascular malformations can occur. And also the dysregulation in the central nervous system causes mental retardation, intellectual deficits. The fourth category that has emerged after the 2015 years and is still not complete, I guess, is the category of mosaic Rasopathies, where mostly oncogenic mutations appear in a mosaicism in cutaneous and other cells. And these include mainly these neurocutaneous syndromes like Schimmelpenning, neurocutaneous melanosis, and other syndromes. And I will briefly show some pictures. So this is taken from a publication by Hable et al. Shows a typical Schimmelpenning-Feuerstein-MIMS syndrome with this linear nevus sebaceous. And these patients may also have besides cutaneous abnormalities, CNS abnormalities, ocular abnormalities, skeletal, and some types of tumors which you will recognize as RAS-specific tumors during this presentation. And this syndrome is mainly related to HRAS G13R mutations and rarely to specific KRAS mutations. NRAS mutations, oncogenic mutations in the mosaic state, cause typically the giant cell melanocytic nevi, and they can be associated with extracutaneous manifestations in the brain, then it's called neurocutaneous melanosis, and with other extracutaneous features. And there are less common variants of mosaic rasopathies, including this phacomatosis pigmentokeratotica, which is also caused by HRAS, the same type of mutation. So obviously it's another cell type that is more affected. And other rare conditions included in this category is, for example, the ocular ectodermal syndrome, which is caused by specific KRAS mutation, which differ from the ones that cause the other conditions. And you see here also that besides these skin defects, these patients have epibulbar dermoids and also have these bone cysts, and may also have keratinocytic nevi. So we see that this rasopathy spectrum includes more complex phenotypes by systematized mosaicism, and the elements of them include single lesions that have, of course, the same mutations like single epidermal nevi or melanocytic nevi, vascular malformation, non-ossifying fibromas, giant cell tumors, epibulbar dermoids, and other tumors. So it seems that the critical point for the extent of such as mosaic rasopathy is the timing of the mutation, and if we have an earlier event, we get a more systematized distribution, and a late event will probably result in only a single lesion with these characteristics. And you can, of course, ask, are we all rasopathy mosaics? If you look at your skin, you will find so many of these dark brownish macules, and I can guarantee you that every one of these macules has a RAS pathway mutation, mostly BRAF. Finally, the fifth category, which overlaps, of course, with the mosaics, are RAS tumor types that are especially RAS dependent. So these include not only JMML, I mentioned already, but also the giant cell tumors of the jaw, bones, non-ossifying fibromas of the bone, and arteriovenous and other vascular malformations. And these have in common that these lesions may occur in the context of rasopathies or mosaic rasopathies, as I have shown you, but if they are occurring as non-syndromic singular lesions, they always or almost always have somatic RAS pathway mutations. And you see that these discoveries have been made in the very recent years, 2017, 2018, when first groups identified MEK1 mutations in the extracranial and KRAS mutations in the intracranial arteriovenous malformations. And even more recently, it was shown that the non-ossifying fibromas of the bones have KRAS or FGFR1 or even TRPV4 mutations, and the giant cell lesions of the jaws have also RAS pathway mutations. And the story is still not over and completed. And quite recently, it was this was only a case report of a congenital pulmonary airway malformation with KRAS mutations. So what can we conclude from this? There's obviously a dualism between, on one hand, mild RAS pathway dysregulation that is tolerated in the germline, if it's a constitutional mutation, and then has a systemic distribution and causes a developmental phenotype that affects organs or the whole organism. And on the other hand, we have the strong RAS pathway dysregulation that is tolerated usually only as a post-zygotic event, is lethal in the germline and has a focal distribution, and you can really see where the mutation is because it leads to a dysplasia or sometimes oncogenesis of the phenotype of the tissue of affected cell. Or in other words, we have these strong mutations, somatic mutations that can contribute to oncogenesis. The same mutation, like for example, PDP11 E76K, which is typical for JMML, for somatic mutations in JMML, the same mutation would probably result in early embryonic loss and will never appear in the germline. But if it occurs as a post-zygotic event, it can survive by mosaicism, like for example, KRAS G12D in Schimmelpenning syndrome. And on the other hand, the mild mutation that is present in the germline leads to perturbed embryogenesis and causes this Noonan-like phenotype as a readout. And by secondary events that differ in the probability from the different conditions, tumors may also occur in these conditions. So they are all some kind of tumor predisposition disorders. And we know a little bit about these Rasopathy-associated tumors. Of course, everyone knows about NF1-related tumors, and they all need a loss of heterozygosity or loss of the wild-type allele. In other conditions like Noonan's, for example, the probability of such a secondary event that leads to tumorigenesis is less, and we actually do not exactly know what the mechanisms are. And together with Christian Gratz and the German Kinderkrebsregister, we have conducted an epidemiological study that confirmed again that Noonan syndrome is associated with an increased risk of tumors, and Costello syndrome with a really strong increase in tumor risk. And the tumors that were observed in this cohort were the same. We knew already the JMML and other leukemias in Noonan, and also brain tumors. And the rhabdomyosarcoma is a typical Costello-associated tumor. And from this, surveillance guidelines have been proposed. And for Noonan in general, because the tumor risks are about 1% in absolute numbers, no specific surveillance is warranted, except for the cases that are considered as risk genotypes. Very few mutations are associated with increased JMML risk, and Sybil gene mutations are included in this. There is a recommendation for physical exams and blood counts until the age of 5 years, every 3 to 6 months. And Costello has its own tumor surveillance recommendations. These different types of rasopathies also are important to consider for diagnostics. So, of course, a germline rasopathy, you can demonstrate it as a mutation is present in every cell. So you can find it in every cell. You can draw a blood sample or saliva, and you will find it. But mosaic rasopathy diagnosis is much more challenging because you need to have a lesional biopsy, because you would expect the mutation to be only in the lesional cell or tissue. And this can be quite difficult if you consider, for example, a vascular anomaly to pick the right tissue, and some other strategies like cell-free DNA may help, but only with very extended mosaicism. I want to talk a little bit about phenotypic variability, because you have already seen how variable these conditions are, but what is the basis for this variability? And if we consider phenotypic variability, we have to consider genotype-phenotype correlation, so the variability that's really related to the individual genotype. And of course, for every condition, we have also genotype-independent variability. And the genotype-related variability can be within the same gene or between the genes. And I will give you some examples. So I showed already this slide where to show you the the overlapping but distinct conditions. And this is quite well reflected by the genotypes that we know now. And if you just compare, for example, the CFC syndrome patients with BRAF, MEK1, MEK2 mutations versus Noonan syndrome with the most common Noonan syndrome associated mutations, you see that also there are quite some overlap for many things. There's a clear difference in the CNS related complications or mental, more severe intellectual disability in seizures, which is almost exclusively present in and also quite constantly in CFC syndrome. And we have conditions that have a distinct phenotype, like this Noonan syndrome with loose anagen hair, which is related to SHOC2 or PPP1CB mutation. And it is quite well explained by the biological role of PPP1CB SHOC2 together with MRAS. They form a ternary complex, which is a modulator of RAF. And so we have an explanation for similarity of the phenotype for these two genes. And also within the Noonan syndrome spectrum, and you're aware that we know quite a lot of mutations that cause Noonan syndrome, we see genotypes or gene-specific manifestations regarding, for example, the growth, the frequency of specific heart defects. So hypertrophic cardiomyopathy is, for example, very much associated with RAF and RID1. More severe short stature is typically associated with SHOC2, but we also see that, for example, multiple nevi, so tumor-like lesions, are especially found in RAF1 patients. Giant cell lesions have a clear association with SOS1, and so on. Besides these gene-specific variability, we see also that a specific mutation within the same gene can cause a considerably different phenotypic expression. And this may rely on one hand, on the size, so the strength of the disturbed protein function, but also on the mode of the disturbed protein function. I can also give a few examples. So we see, for example, that specific mutations of HRAS are associated with a more severe and sometimes lethal course of Costello syndrome. This includes especially the mutations G12C, D, and V. And if you see, if you compare here the somatic mutations that are observed in cancer with the germline mutation in Costello syndrome, we see that the milder end, G12S, and this affects only this is the same codon, yes, different exchanges, the same codon. The milder spectrum, end of spectrum, is more frequently observed in the germline and more tolerated, obviously, in the germline. And G12V is extremely rare in Costello, but it's the most common oncogenic mutation. And the same or similar things are true if we compare Noonan syndrome patients that have JMML versus Noonan syndrome without. And this is taken from a work by Strull et al., the Paris group of Helen Cavey. And you can see that we have overrepresentation of specific mutations in the JMML associated groups that are less frequent or have a lower proportion in the Noonan syndrome without JMML. And this, a similar thing can we see in prenatally diagnosed cases that run into this nuchal edema, pleural effusion, hydrops course. And we see an overrepresentation of some mutations, some even matched with the oncogenic mutation, some do not so well. And we even see mutations prenatally that we never see in a live-born child. And therefore, there seems to be a gradual a gradient of strength of the dysregulation that leads to a variable bottleneck in prenatal survival. And some of the mutations we'll never see at birth. We can find them prenatally by amniocentesis, the very severe mutations even not there. And we have also some prenatal deaths for other mutations. So this bottleneck has a different size, but we see, we see for the milder mutation, Noonan syndrome with low risk of leukemia, the ones that are, have these stronger effects are among the children with increased risk of leukemia, and the other ones we do not see at all. And they may survive as mosaic, but we don't know this mosaic phenotype so far. Another example for qualitative differences that lead to phenotypic differences are the PDP11 mutations that lead to a phosphatase hyperactive PDP11, which is a classical Noonan syndrome phenotype mutation, and the phosphatase inactive that are associated with Leopard syndrome. Please keep in mind that this is not a loss of function mutation. It has a different gain of function effect, but without phosphatase activation. And last example for that, among the KRAS, mosaic KRAS diseases, we have the Schimmelpenning, epidermal nevus syndrome and the oculoectodermal syndrome I showed already. And we have a clear difference in the mutations we see. And this is well explained, but not understood physiologically, but biochemically, that the mutations that occur in oculoectodermal syndrome activate RAS by a GEF-independent GTP exchange that means that these RAS molecules load themselves with GTP, so activate themselves without a signal from source or other GTP guanosine exchange factors. And the other mutations that are associated with Schimmelpenning, they lead to a gap-resistant RAS protein, so they cannot be turned off. And this seems to be a difference, and it is also reflected by different expression patterns. So we see that this phenotypic difference is reflected by a functional difference, but we do not understand how this functional difference leads to these different phenotypes. And in the case of mosaic Rasopathies, as I showed already this slide, we have to consider another dimension of variabilities. This is the timing of the mutation, but also the extent and distribution of the mutations, the affected cell and tissue types. It makes a difference whether a mesenchymal or an epidermal or ectodermal cell is affected, the timing of the mutation. And this all determines the phenotype of a mosaic Rasopathy. So what can I say about my initial slide? So I've shown you that colon cancer and other RAS cancers that have RAS mutations, these cancers have a RAS pathway activation as one element of a complex genetically aberrant cell clone. The congenital melanocytic nevus or other nevi are an example for the tissue-specific phenotype of an oncogenic mutation on the RAS pathways that affect a specific type of cells. And what we see is what this mutation alone does in contrast to these complex genetically aberrant cells in tumors. The Noonan syndrome is a phenotype of a mild systemic RAS pathway activation, and hydrops may sometimes be a phenotype of a severe systemic RAS pathway activation that is prenatally lethal. And neurofibromatosis we have to understand as a dual phenotype of a mild systemic RAS pathway activation that leads to some Noonan-like features, plus a focal oncogenic activation that results from a second hit in a somatic cell. So with this, I want to thank you for your attention. And I will show you my collaboration partner and funding sources. Thank you very much. I hope I have not been too long.
No, you were great. I mean, and thank you for your Greek, both in the beginning, Rasopathies, everyone noticed that, and your thank you in Greek. Okay, well, thank you. What can I say? You made us again, go through known entities and looking at them, with another view, from another view, with another eye. I would like to ask if there are questions or comments from the floor. We have very few people, as you understand, as audience, and from home. And if Sophia wants to make some comments, I'm sure she does.
My first comment, Dr. Kosmides, is a great thank you to Martin Zenker. He traveled us to this wonderful imaginary world of rasopathies, and you unraveled so many different entities that exist under this term of rasopathy. And I'm sure that we're still learning and try to find new pathogenetic underlying mechanisms. So thank you so much. But if I may ask, there is one thing that I would like to ask you. Two things. The first is, what defines, if there is any knowledge on this, what type of mosaicism will prevail on what tissue? And my second question is, if a rasopathy evolves into cancer, is it only within the pathway of the RAS-MAPK disturbance that causes the oncogenic final event, or there might be other strikes or events outside of this well-known, let's say well-known, because I know it has branches, pathway? These are my two major comments and questions.
Very good question, and thank you for your comments first. And of course, it is fascinating to see how these things begin to fit together. And this is my fascination about it. But we still see, of course, these great gaps of lack of knowledge that we have. And there's still so many things we have to understand. So regarding the tumor formation on the basis of a rasopathy, you're certainly right that at least a malignant tumor will never result from just RAS pathway activation. So we see already in the mosaic rasopathies that are severely activating mutations that really leads to constitutionally full, strong signaling through the RAS pathway is not able alone to lead to a tumor. It causes these cutaneous phenotypes that we have seen. So this is obviously not sufficient. And the question is the second event always in the RAS pathway, or are other events needed? And for some tumor types and some, we have some insights from the tumor types we know. So for example, for the NF1, it is very clear also for LZTR1 that a second event, that's a classical tumor suppressor mechanism. And these are the inhibitors of the pathway. So you have to loosen the first break and then loosen the second break. And then this is the first step towards tumor formation. And of course, you know that even an NF1-related malignant tumor will never result alone from the biallelic loss of NF1. So second and third and fourth steps have to occur. But for the NF1, we know that the second step is always the loss of the wild type allele. For the Costello-associated tumors, we have shown in a small paper in 2015, I guess, together with Christian, that it is likely the UPD of 11P, which contains, as you know, this Beckwith-Wiedemann region with this effect on proliferation. And HRAS is on 11P. And the secondary event in Costello that is always, almost always present is the UPD on this chromosome that leads on one hand to the duplication of the paternal mutation, because the mutation is almost always on the paternal allele. They occur on the paternal allele. And secondary, we have this paternal, this paternal isodisomy, which is this Wiedemann-Beckwith, and is a recurrent motif in childhood tumors. And interestingly, and this is really, really interesting, embryonic rhabdomyosarcomas that are not associated with Castello do also have HRAS and UPD11, but they have the HRAS as a second event. And this shows us that the tumors need both of these events, but the duplication of the HRAS mutation is probably not an important driver for this. So this is what we know. We know quite little about Noonan syndrome associated tumors. What I can say, and I have written it in one of these slides, that on a recent Rasopathy meeting last year, it was shown, and we have also some experience that these brain tumors that occur in Noonan syndrome very often have the somatic FGFR1 mutation. And this seems to cooperate with this PDP11 mutation in some way we do not understand. So it may lead to some augmentation of this relatively mild signal overactivation that is present in every Noonan syndrome cell. But I think it's really depending on the condition, on the partners that can cooperate, and at least for a malignant tumor, of course, it's not RAS pathway alone. And the first question you had, I think about mosaicism, it is really difficult. So there are so many variables at what time in embryonic development that mutation occurs, in which tissue, and we see you see some specificity of so NRAS, which is melanocytic, and HRAS with this epidermal nevi, but there are overlap phenotypes which are quite interesting. So we have published one case with a classical NRAS mutation, and this patient had, besides this melanocytic nevi, also epidermal nevi. So we do not understand what drives the specificity for these genes. It's probably not that. Or let me say, if the RAS pathway is overactivated in a cell, it has a specific type of phenotype, of cellular phenotypes that develops, and it's probably and this can be probably caused by any of the RAS genes, but there is some reason for this diversity that we do not understand.
Thank you very much. Excellent answers. Thank you very much. Very enlightening.
Well, it was another lecture, this one. I mean,
Excuse me.
No. We enjoyed that. I'm just saying that, we could listen in to you, up to very late tonight, because you have so many things to tell us. And I want to thank you. I don't know if there is any question. Dr. Idola has a question. Yeah. Or come up here or over there. Okay. Okay. Come here.
Okay. Hi, I'm Vita Ridola, I'm pediatric oncologist. I have two questions. The first question is, you show that there could be several genes that could be involved in the Rasopathies. What if we have a child with a tumor and a mild phenotype without the typical clinical hallmark of a particular Rasopathy? What is your suggestion about which test we should perform to diagnosis, to make the diagnosis? Is it NGS, or there is a panel? Should we go for a panel or a few genes? So diagnosis.
Yeah, may I answer to this first question first? So actually, I think the way of diagnostic testing is, of course, depending on what is available in your lab or in your lab partner. So if there is if you consider a Rasopathy for a child with a tumor, then of course you have a reason to do germline testing of the Rasopathy genes, either with a gene panel or an exome-based analysis. I think this is what is usually done today almost nobody does Sanger sequencing of single genes for this question. The other question is, of course, if it's a very, very mild or only subtle Noonan-like or Rasopathy-like phenotype in a tumor, you cannot be sure, of course, that it is really a germline mutation. And if you, for example, consider this could be a mosaicism, it may become quite difficult to find it. But you have the tumor, and if your tumor by molecular analysis indicates that there is a mutation that could also be in a higher proportion of body cells, either in mosaicism or even in germline, then you can do, of course, the germline testing afterwards, after you have the molecular results from the tumor or the leukemia.
Thank you. And my second question is for patients with Rasopathies and, for example, for Costello syndromes. Are there recommendations about treatment? For example, if they develop a sarcoma, should we avoid radiotherapy? Are there special distinction with the treatment compared to another normal patient?
Yes, I think everything that is available there is not more than expert opinion. So basically, the treatment is the same, for example, for embryonic rhabdomyosarcoma. What some people considered is using MEK inhibitors, and I have not mentioned that, of course, with these RAS pathway inhibitors, MEK inhibitors, RAF inhibitors, could be, of course, therapeutic options for germline or mosaic or even only Rasopathies in general. Because this is still too early, we have no clinical trials, except, the selumetinib in NF1-related tumors has an approval, but everything else is on off-label basis. I recently had a discussion for a very severe embryonic rhabdomyosarcoma in the Costello patients where the standard treatment did not lead to success, whether MEK inhibitors should be tried. This is always an individual decision, off-label, compassionate use, where you cannot provide any evidence that this is really working.
Yeah. May I add on this point, please? I have read articles from you supporting that this inhibitory effect cannot be strong, cannot last for a long time, and cannot be the only one. Do you still support this idea? And if this is the case, do you think that this inhibition should be added on this tumor at diagnosis together with chemotherapy, and not only as in relapse cases or as a supportive compensatory surrounding?
Yeah, I think the number of cases is still too small that we can really have clinical trials to demonstrate at what stage this could be considered. So everything that is done is off-label at the moment. And since I'm not an oncologist, I'm a little bit reluctant to give any prescriptions or recommendations for that. The other point is whether these non-oncologic manifestations of Noonan syndrome, like, for example, severe hypertrophic cardiomyopathy or other things, can be treated by MEK inhibitors. And there is some evidence that this really works. And we have currently one paper under review that reports 25 patients with severe hypertrophic cardiomyopathy treated with a MEK inhibitor, trametinib, where we observed some improvement, but still my opinion is that with an inhibitor, you will probably not be able to restore the full function and full dynamics of a signaling pathway. Because if you have an overactive protein and then you have an inhibitor against it, it still will not, this inhibitor will also affect the wild type, and the dynamic range of regulation will disappear. And therefore, I think there is a natural limit in all this pharmacological inhibition for treating rasopathy manifestations. And maybe other strategies will emerge, and I'm thinking, for example, for a selective knockdown of the mutant allele, which could be an option. And so as there will be, it will be fascinating to see what comes next in this field in the next years.
Okay. Well,
Thank you very much.
So much. Thank you for being with us this Saturday. And how is the weather in Magdeburg? Good?
Thank you very much for inviting me, for having so much time for me. So I really apologize for stealing your time. You were already behind the schedule, and now I have even exaggerated your delay.
Thank you so much.
But I will leave now because I cannot understand
our Greek.
Anyway, but I was happy to be with you and wish you a very good meeting and a nice weekend, everyone who's attending.
Thank you so much.
Thank you very much.
Thank you. Bye-bye.
Thank you for being with us.
Thank you.
Bye-bye.